Good morning and a very warm welcome to everyone. Today's session is on optic nerve disorders, Demystified. It focuses on some of the challenging cases in optic nerve pathology. So we are fortunate to have some of the experts giving talks on various topics. And we are so fortunate to have Dr. Kausalya ma'am as our expert panelist. She's a consultant and professor from Aravind Eye Hospital, Madurai. She's an eminent cataract surgeon and a renowned neuro-ophthalmologist with many state, national, and international publications. She's a clinical in charge of vision centers at Aravind Eye Hospital, Madurai, which is a boon to the rural community. We welcome you, ma'am, and we welcome every one of you. So we'll go to the first talk. The first talk is by Dr. Nadasha Radhakrishnan. She doesn't require an introduction. She's well known to all of us. So she'll be talking on unraveling disc edema. So over to you, ma'am. And I kindly request all the speakers to stick to the time so that we can have a good discussion at the end. For ma'am's topic, we'll have the discussion just after. Can you all see the screen presentation? Is it okay? No, not that. Blocking. Is it okay?
Today my topic is unraveling disc edema. So we are just going to look at an overview of what all conditions we should think about when we see disc edema and how do we go about investigating. Because each one of these conditions is covered in detail later on, so I have not gone into detail about any of them. But always remember that disc edema is a sign, it is not a diagnosis. You know that it is swelling of the optic nerve head due to obstruction of axoplasmic flow. And when you have it because of raised intracranial pressure, then we call it papilledema. And in papilledema, the primary event is axoplasmic flow stasis that causes intracellular fluid accumulation. And underlying mechanisms of the disc edema vary depending on what is the condition that is causing the disc edema. So when you look at classification of disc edema by pathophysiology, we already said raised ICP papilledema. Ischemic can be arteritic AION or non-arteritic. Inflammatory or demyelinating will come in the optic neuritis and in the infectious optic neuropathy. Venous or vascular congestive disc edema you will get in CRVO, in papillophlebitis or the non-ischemic CRVO, and in a hypertensive and diabetic papillopathy. Compressive in optic nerve sheath meningiomas, gliomas. In sarcoid lymphoma also you can get compressive or infiltrative type. And the toxic metabolic in ethambutol, methanol, INH toxicity. Hypotony can cause hypotonic disc edema. Traumatic optic neuropathy can sometimes cause disc edema prior to the pallor, and hereditary or mitochondrial causes in Lebers you can have hyperemia and telangiectasia of the optic nerve head. Clinical classification is according to the course of the disease. Is it acute, is it subacute, or is it chronic? You know that the ischemic events are almost always acute. Inflammatory are also mostly acute. And sometimes malignant hypertension and papilledema are also acute, rapid rise in the disc edema. The subacute causes are the compressive ones, the infiltrative ones, and the chronic ones are the chronic infiltrative conditions and long-standing papilledema. But for us, clinically, the easiest way to decide what kind of papilledema is, what kind of disc edema it is to look at whether it is one eye that is involved or both eyes that are involved, because the causes are different. When you're looking at a unilateral disc edema, then you're looking at conditions like optic neuritis, ischemic optic neuropathy, CRVOs, and compressive optic neuropathies, diabetic papillopathy, neuroretinitis, hypotony if it is post-op or traumatic, and the traumatic optic neuropathy. However, if you are looking at bilateral, then you must think about papilledema first, malignant hypertension, the bilateral infiltrative conditions, severe systemic illness, bilateral optic neuritis mostly in children, and bilateral diabetic papillopathy, which is also rare. Now, what to ask in the history? So, one, we already said onset. You want to know whether it has been sudden or the symptoms have come in over the days to weeks, or is it gradually over many weeks to months? Next, you should know whether the patient has pain, especially pain on eye movements. Patient may not complain of pain, but if you ask them whether there's pain on eye movements, they will give you that piece of clue that it is optic neuritis you're dealing with. Color vision, whether they have any symptoms related to color vision, and always remember it is not a gross color vision loss that you will get. You will only get as a mild red washout. So that has to be specifically asked. Then any recent history of surgery or trauma can be asked. Systemic symptoms of raised ICP, headache, vomiting, jaw claudication or scalp tenderness, history of hypertension, diabetes, absolutely important, whether they have been on any long-term medications, and any infection exposure. Once you have examined, you can use this part of the history retrospectively also. So in your examination, you're going to look at the laterality first. You're looking at visual acuity and color vision. You're looking at presence of RAPD. In the optic nerve appearance, what should you look for? You should look for, is it a pallid disc edema or is it a hyperemic disc edema? Are the disc margins smooth or are they lumpy? And how much elevation is there? Vessel obscuration. Are the vessels on the disc clear or the vessels on the disc are completely obscured? The amount of swelling. You should always remember that except in early papilledemas, it is only papilledema that can produce a huge amount of optic nerve swelling. The early papilledemas and optic neuritis almost always cause only very little optic nerve swelling. Hyperemia will be more evident, but the actual swelling will not be much. Peripapillary changes, are there those patterns, folds? Is there any atrophy in the peripapillary area? Are you looking at something like a myopic disc that is fooling you into being disc edema, and because it is tilted? Then you also have to look at the rest of the retina. Don't just look at the disc, look at the rest of the retina, especially in the posterior pole. All the hemorrhages, cotton wool spots, are there a lot of hemorrhages all the way up to the periphery, telling you that it is a CRVO, and whether there is a macular star. Now in this case, this is a 30-year-old female with intermittent fever for 2 weeks, developed headache, neck pain, photophobia and phonophobia. Even without looking at the disc, we will come to a clinical feeling that this patient is probably having papilledema because all the symptoms fit in with papilledema. Unilateral causes, optic neuritis. Typically, it's a young adult, often female, and often subacute. I think we have a full talk on optic neuritis, so I will not go into the details, but always remember that unlike papilledema, in optic neuritis, RAPD is a very clearly visible sign. Ischemic optic neuropathy, again, it will be sudden onset, painless. If it is the arteritic type, it will be very older age group, and if it is a non-arteritic type, usually around 50 to 70 years. And you know that the ESR will be very highly elevated in arteritic, and in arteritic, the disc will be extremely pale. But in non-arteritic, usually more of a sectoral edema with along with the signs of your altitudinal field defect. The actual decrease in vision can vary. It can be very mild, like 6.9, 6.6 parts, to really severe 6.60. And in the arteritic type, it can even be perception of light or counting fingers. CRVO, please remember that disc edema is only an incidental sign. But sometimes in the non-ischemic type, what was called papillophlebitis earlier, CRVO can have a misleading sizing because the hemorrhages are not much. Let me go quickly into a small flow chart that has been made. Pseudopapilledema also, I believe there is another session. So let's go to this flow chart. So you have disc edema. Find out whether it is true or pseudo. Is there a lumpy appearance? Is there high hypermetropia? Then if it is true, you go into unilateral or bilateral. Unilateral, is it sudden onset or does it look like a chronic one? If it is sudden onset, there is pain present or pain not present? Pain not present, you may be looking at ischemic optic neuropathy. Pain present, optic neuritis. Is the posterior pole showing other findings? Hemorrhages in CRVO, choroidal folds in hypotony, macular star in neuroretinitis. If it is chronic, is there any EOM restriction or proptosis? Is the other disc pale? Are you looking at a Foster Kennedy? When it is bilateral, whether there is raised ICP or not raised ICP, and then you can figure out the rest using this flow chart. So with that, I come to the end of my overview of disc edema, and I also take this opportunity to invite all of you to Ignite, a dedicated uveitis CME in January 10th and 11th.
Thank you. Thank you, Dr. Natasha. Thank you, Dr. Natasha. It was an excellent presentation. Only one more point I would like to add is the central fields. So in optic neuritis, central or centrocecal scotoma will be there. In AON, altitudinal type of field effect will be there. And in papilledema, enlargement of the blind spot initially. Later on, going in for peripheral constriction and total loss of vision. So all these have to be considered. And if residents are here, 5 points to remember while asking the history, what Dr. Natasha had told already. Duration, first is laterality, next is duration, third one is onset, fourth is pain, and fifth is progression. If you ask these 5 points, you can arrive at a diagnosis 90% of the times. Thank you.
Thank you. Thank you, Rana, for this opportunity.
Ma'am is going to leave. So any questions from the floor? The rest of the questions we can take after the whole talks. So next talk is by Dr. Rehanha. She's consultant in Amarda Institute of Medical Science, Kochi. So cracking case of optic neuritis is a topic. Over to you. Good afternoon, everyone. So cracking cases of optic neuritis. Optic neuritis, you know that the largest trial which was done, that is the earliest and the largest, was done years back. And that was done in cases of acute optic neuritis. And it came to a conclusion regarding the prognosis, the outcomes, and also the clinical profile of patients with optic neuritis. And it concluded that the visual function after treated or untreated optic neuritis is the same, but it could be hastened with IVMP. But we should note that these patients were all Caucasians, and the clinical profile and the outcome of the patients in our population is a little bit different from that of the West. So how is optic neuritis in India different from the West? We have more of atypical presentation and a poorer visual prognosis, and more of NMOSD or neuromyelitis optic spectral disorders and other atypical optic neuritis than the West. So optic neuritis itself, you know, it is divided into typical and atypical. Typical is a unilateral, subacute loss of vision seen in young females between 20 to 30 years with pain on eye movements, visual acuity better than 660 and has a good visual outcome, and retrobulbar neuritis. So let's go to a typical case. So this is a 31-year-old who presented with decreased vision and pain on eye movements for 3-day duration. The visual acuity in the right eye was 636, left eye 66. There was RAPD and defective color vision. We can see that the disc appears normal. So it's a case of right eye retrobulbar neuritis, which is typical. As ma'am said, here the patient presented with a field showed a centrocecal scotoma. And all cases of clinical isolated syndrome, which includes optic neuritis, should have an MRI of the brain and the orbit with the contrast to be done. One, to look for the cause, if there is any inflammatory lesion in the optic nerve, and also brain to see if there are any demyelinating lesions to find the risk assessment for conversion to MS and other demyelinating conditions. So she had this MRI brain which showed hyperintense lesions in the periventricular area. So she was treated with IVMP as ONTT, followed by oral steroids. Her visual improved. She was referred to neurologist who did the CSF examination. In with patients with MRI findings should be referred to the neurologist, and they look for oligoclonal bands to know the risk assessment of MS, and the patient was treated on disease-modifying therapies as well. So that was a typical optic neuritis. Now we'll go to the next case, which is a 49-year-old lady, which is outside the typical age group, with decreased vision of 2-day duration in the left eye, and visual acuity, hand movements. And the left eye is showing disc edema. So atypicality, age outside, severe vision loss, and disc edema. OCT confirmed increase in peripapillary RNFL thickness. So that's a coronal section of the MRI. Pointer. So if you look at the left eye, centrally, that is the optic nerve, which is showing hyperintense increase in contrast, but I'm going a bit more posteriorly. So it's again increasing. So that is a chiasm. So that area also, the optic nerve is showing enhancement, which means the posterior part is affected and a longer tract is affected, which is in favor of NMO. And that's a spinal cord. You can see that there is hyperintense area here, which is involving almost 3 disc segments, which is also kind of more specific for NMO. So this patient again should be treated with IVMP. CSF studies showed NMO positivity. So diagnosis is left optic neuritis with neuromyelitis optica. So this patient's vision improved, and the long term she was kept on MMF. So what we should know that cases of NMO, sometimes they don't improve with IVMP. In such cases, they should undergo early plasma exchange under the care of neurologists. So it's important to differentiate and diagnose NMO, because patients who are started on interferons will worsen with interferons if it is NMO. So what is NMO? It's a demyelinating disease, more common in Asian population, with a vision loss which is severe and rapid, and with a worse visual prognosis if not treated. There is a consensus regarding NMO. I'm not going into the detail, but there are 6 core clinical characteristics, out of which 1 is optic neuritis. So let's now go to atypical optic neuritis and when to test for NMO or MOG. So if it is age outside the 20 to 45 years, if it's bilateral, painless, vision not improving or worsening on systemic steroid, it recurs once steroids are tapered, or if there is severe disc swelling. So consider for any optic neuritis which is not typical. So these are the causes of atypical optic neuritis. There is an entity called chronic relapsing inflammatory optic neuritis, which is steroid dependent and steroid responsive without an underlying cause that we can find. Then other causes, SLE, vaginous, autoimmune, NMO, MOG related, and infections. So I just show you this table, which would help you to differentiate multiple sclerosis, NMO, and MOG-related optic neuritis. As I said, multiple sclerosis is a typical optic neuritis which presents in a young adult female. On the other hand, NMO, middle-aged adult female. MOG can affect any age, any sex, and we are recently seeing this more in children. Multiple sclerosis more in Caucasians, NMO more in Asians, and MOG can affect any race. So as a typical optic neuritis, it causes mild to moderate vision loss in multiple sclerosis. But in MOG and NMO, it is severe vision loss at the onset. But there is good recovery with multiple sclerosis and MOG. ONTT says that even without treatment, the cases of typical optic neuritis with MS will improve, isn't it? But NMO and MOG definitely requires treatment, and MOG has a good recovery with IVMP. And typically MS is retrobulbar neuritis, but the other 2 can present with disc edema. And in the MRI, typical one presents with short enhancement of the optic nerve, NMO longer enhancement with including the optic chiasm, and MOG, it is typically described as a perineural enhancement, that is enhancement outside the optic sheath. So quickly go to the third case. It's a 7-year-old girl, decreased vision, severe vision loss, hand movements with grade 3 RAPD. So there was bilateral disc edema and peripapillary increased thickness, which was confirmed on OCT. So optic neuritis on MRI. The serum and CSF MOG antibody was found to be positive. She was treated with IVMP and she improved. So that's a typical case. Usually it is a pediatric population with disc edema, severe vision loss, and a good response to steroid. And with one episode, usually the neurologists don't start on immunosuppressants. It starts only if it recurs. To summarize, it's a stepwise approach is required for the diagnosis and management of acute episode of optic neuritis. Any atypical neuritis should be thoroughly investigated since the diagnosis and prompt treatment is key to prevent relapses. Contrast MRI of the brain, orbits, and spine are indicated for diagnosing various causes. And it should be noted that NMO-related optic neuritis may actually worsen with infrons, and differentiation should be made before initiation of treatment. A long-term treatment protocol is needed to prevent further attacks and decrease the disability burden. Thank you. Next, we have Dr. Nia talking about, the topic is papilledema versus pseudopapilledema. She's a consultant at Aster Hospital.
Good afternoon, everyone. Today's my topic is papilledema versus pseudopapilledema, a clinically diagnostic dilemma. Going to the first case scenario, we have a 20-year-old female presented with episodes of hemicranial pulsatile headache, mild tinnitus, and depressive symptoms. The patient gives history of vague trauma 2 weeks back, and she was sent from internal medicine to rule out papilledema. On examination, her vision was 6/6, color vision was normal, EOM was full, no pain, no diplopia, anterior segment was normal, and no RAPD noted. Dilated fundus showed bilateral disc edema, otherwise the fundus was normal. And her BP was checked, it is normal. And her fundus showed papilledema or disc edema in both eyes, and OCT RNFL was taken, which confirmed the peripapillary RNFL thickening in all quadrants, and visual field was taken. Definitely the enlargement of blind spot was noted in both eyes. And how we proceed, we have to check the patient's BP. MRI with MRV has to be taken. Lumbar puncture and CSF analysis has to be taken. Any history of drug intake, such as OCPs or any antipsychotic drugs, anything has to be checked out. So this patient's BP was normal. CT MR imaging was done. It was normal. Brain parenchyma along with mild tortuosity of the optic nerve noted. And CSF studies showed increased opening pressure and normal CSF composition. What's the diagnosis? It is idiopathic intracranial hypertension. And see how we manage it. It's by CSF drainage by LP. TAP Diamox 250 mg/BD was started, and the patient was followed consecutively, and disc edema was resolved by 2 months of treatment, which we can see in the OCT also, that peripapillary RNFL thickening has reduced. And coming to some theory part of papilledema, it is optic disc swelling, which is secondary to the increased ICP. It is the hallmark of idiopathic intracranial hypertension. It may or may not be associated with retinal hemorrhages, folds, cotton wool spots, or exudates. And the threat of vision loss it can cause is related with the severity of the papilledema. And before going to the pathophysiology, just a brush up for anatomy. The optic nerve sheath is an extension of the dura and arachnoid matter with subarachnoid space terminates 3 mm before the scleral junction. So whenever the increased ICP, it transmitted along the subarachnoid space to the optic nerve, which causes the axoplasmic flow blockage and stasis in the optic nerve head. And this can cause extracellular edema due to the swelling of the axons as well as venous congestion causing the secondary vascular changes. Factors usually affecting the severity might be due to the degree and the speed of ICP rise, the vulnerability of the optic nerve fibers to the external compression, optic nerve sheath width and compartmentalization around the optic nerve as well as the size of the optic disc. How to grade papilledema? It's modified Frisson grading. It's grade 0. It ranges from grade 0 to grade 5, whereas grade 0 is a normal disc. Grade 1 is a nasal C-shaped halo. Grade 2 is circumferential halo. Grade 3 is a moderate with mild obscuration of the blood vessels over the disc. Grade 4, marked papilledema with obscuration of one or more of the major blood vessels of the optic disc. And grade 5, almost all of the blood vessels over the disc is obscured. Retinal folds are seen in true papilledema, which is a circumferential papillary retinal folds known as Patton's lines, and the radial folds which are extending into the macula. With treatment, this may regress and it is an indicator of good response to the treatment. Retinal hemorrhage may be present either with papilledema or pseudopapilledema. So we can't put it as a criteria. And causes of papilledema: expanding mass lesions, cerebral edema, intracranial hemorrhage, compression of the ventricular system in the posterior fossa, venous sinus thrombosis. It might be due to the infectious etiology as already discussed, or it might be due to pseudotumor cerebri. Coming to another case scenario, a 38-year-old gentleman who came for general health checkup with anatomic aphasia, which progressed over a period of 1 month, except deep tendon reflexes, increased deep tendon reflexes positivity, nothing was other in the systemic examination. Ophthalmic consultation was again sent to rule out papilledema. His also vision, color vision, confrontation, anterior segment, everything was normal. And fundus showed bilateral papilledema. Immediate MRI with contrast was done, and it showed a very huge cystic lesion in the right frontoparietal lesion with causing a midline shift. Coming to the causes of pseudopapilledema. Pseudopapilledema is an anomalous elevation of one or both the optic disc without the edema of the retinal nerve fiber layer. The causes include diabetic papillopathy, toxic insult, metabolic nutritional deficiency, optic neuritis, ischemia, compression from orbital tumors and all. But all these optic neuritis and all can cause decreased vision, which is we are not seeing in papilledema. Coming to case number 3, this is a case which we have a patient presented with history of defective vision in both eyes, with right eye vision 636 and left eye 4/60, and his anterior segment examination, no RAPD, otherwise anterior segment was always also normal, and fundus was showing bilateral disc edema with hard exudates arranged in star pattern at the macula, along with tortuous vessel, arteriolar narrowing with AV cross changes, and his BP was checked, and it has turned out to be 200 to 110, 200 by 110. And we have started the investigations of the patient after sending to general medicine, and routine blood examinations were normal. So the primary hypertension was ruled out as the patient's BP was refractory on treatment, and the patient was evaluated for the causes of the secondary hypertension. Case number 4, this is an incidental fainting which we have noted in one patient, with which we can see a yellowish white crystal-like deposit over the disc. This is the optic nerve head drusen. It is one of the causes of pseudopapilledema. It is caused by a tight scleral canal, which causes the consecutive exoplasmic stasis and extrusion of calcium, hyaline and other proteins. Exposed optic drusen are yellow in color, and it is refractory in structure. And whenever there is a buried optic nerve head drusen, we have to proceed with the B scan to find out the increased refractivity and posterior reduplication artifact. How to skip this illusional obstacle? In papilledema, there will be transient visual obscurations and visual field defects from him, as madam told, it ranges from enlargement of blind spot to the constriction of the visual fields. Spontaneous venous pulsations are absent. Optic disc appearance is dynamic. That means in papilledema, it will respond to treatment. Either it will worsen or it responds to treatment. There will be change in the structure of the optic disc. Whereas in the pseudopapilledema, it will be constant. Obscurations of vessel will be present on the papilledema, and hemorrhages may or may not be seen. Retinal folds are often present on papilledema. And another thing, fluorescein angiogram may show leakage for papilledema, wherein pseudopapilledema it is not there. And symptoms of raised ICP are also present in papilledema. As we already discussed, capillary leakage will be present in moderate to severe papilledema, but not in pseudopapilledema, as well as in visible drusen. IV fluorescein angiography will show a true nodular hyperfluorescence. Visual field, we already discussed, mild papilledema have no visual field defect, but in enlarged visual physiological blind spot is the first visual field defect. It is due to the subretinal fluid around the optic nerve. Moderate papilledema may cause arcuate infranasal visual field defects. With severe or long-standing papilledema, constricted visual field with central sparing can occur. Another bedside test we can use to assess this thing is optic nerve sheath diameter, and it can be used for the follow-up of ICU patients also. Optic nerve head OCT, we can see in raster OCTs, there will be elevation, inward deflection of the retinal pigment epithelium and Bruch's membrane complex towards the vitreous cavity when increased IPC is present. What are the take-home messages? There will be usually no visual field deficit in papilledema. Color vision will be usually normal. Fields to be documented. Ancillary tests can be done if doubtful. Patient has to be followed up with OCT scans. BP is definitely to be checked, and neuroimaging is essential for every cases. Thank you.
Thank you, Nia, for that nice talk. So next we will go to diagnosing and managing ischemic optic neuropathies. Dr. Kiran will be presenting on this topic. He's a VR consultant from Comtrust Hospital.
Good afternoon. I'll straight away start with the case. It's a 56-year-old male, known case of coronary artery disease and hypertension, came with complaints of blurring on right eye on waking up with 6/60 vision and RAPD. This shows sectoral hyperemic disc edema, and FFA done shows sectoral filling defect. And HFA was done, which showed an inferior altitudinal field defect. VVP done showed right a decreased amplitude and mild prolongation of the latency. This is a typical non-arteritic non-arteritic anti-ischemic optic neuropathy. Ischemic optic neuropathy can be classified anatomically into anterior and posterior. Etiology-wise, they can be classified into arteritic and non-arteritic. The blood supply of the optic nerve, it's already discussed, I think, short posterior ciliary artery, and they have watershed zones in its circulation and have segmental supply. That's why they have altitudinal field defect. Non-arteritic AON is the most common acute optic neuropathy in patients over the age of 50. The pathophysiology, the main pathophysiology is hypoperfusion, though rarely occlusion to an emboli can occur. The major risk factor is a crowded desk, optic disc drusen, angle closure glaucoma, marked optic disc edema, and also the location of the watershed zones of the posterior ciliary arteries in relation to the optic disc. Coming to the systemic risk factors, the nocturnal arterial hypertension is considered one of the major risk factors. That's why the patient develops blurring on waking up. Aggressive hypertension can again worsen the nocturnal arterial hypotension. Other systemic risk factors include ischemic heart disease, hyperlipidemia, sleep apnea, malignant arterial hypertension, migraine, aggressive hypertension treatment. Other medications such as sildenafil and amiodarone have been attributed to non-arteritic AON. Usually the vision stabilizes by 1 to 2 months. So any progression after 2 months should raise suspicion. We should think of alternate diagnosis. Lifetime risk involvement of the fellow eye is 30 to 40%, and more importantly, spontaneous visual improvement can be noted in around 40% of the patients. So the treatment is basically focused on controlling the risk factors. So we should avoid nighttime antihypertensives, treat the coexisting diseases, and check for any offending drug. Steroid has been studied in NAION, and some studies have shown improvement up to 70% in treatment group and 37% in untreated group. But many studies have not failed to produce consistent results. Many other treatment has also been tried, like intravitreal anti-VEGF, intravitreal optic nerve decompression, aspirin, but none of these studies have provided consistent results. Coming to the next case, this is a 72-year-old female with history of transient blurring of vision, RAPD, BCV of counting finger vision. She gives history of headache and jaw claudication. A disc shows pale disc edema with ciliary artery occlusion, and FFA shows a large area of choroidal filling defect suggestive of short posterior ciliary artery occlusion. Workup showed markedly raised ESR and CRP, and temporal artery biopsy showed features of granulomatous inflammation, and an arteritic AON was diagnosed in this patient. This is another patient who came with vision loss to PL in the month's time, left eye followed by the right eye, and both eyes showed features of central artery occlusion. On FFA, it showed features of CRAO along with an area of choroidal filling defect suggestive of posterior ciliary artery occlusion, and workup showed GCA. So I just want to highlight that GCA can produce blurring of vision in the fellow eye in a matter of few days. So we have to start the treatment aggressively to prevent blindness. In arteritic AON, giant cell artery is the most common cause. So other rarer causes are vasculitis such as SLE. It's more commonly in elderly, and marked visual loss and amaurosis fugaxis is another presenting feature. The most common systemic feature of GCA is headache, but the most specific one is jaw claudication. Other features are tenderness of the temporal arteries and the scalp. So one thing to remember is in 20% of arteritic AON, they can present with visual problems alone without any systemic features. The ESR and CRP remains the main investigation. Together, they can produce a specificity of say 97%, but in 10% of the patient, the ES and CRP can be normal. Temporal artery biopsy is the mainstay of, gold standard for diagnosis. But we have to remember about the skip lesion. So, a 2.5 centimeter of artery should be collected to study it. The non-invasive investigations include color Doppler duplex ultrasonography and MRI, which can localize the edema and the focal stenosis. It should arthritic AN secondary to GCA should be considered a medical emergency due to the affection of the fellow eye, and also it carries life-threatening complications such as stroke, aortic dissection, myocardial infarction. So steroids should be started immediately and shouldn't be waited for the results of the temporal artery biopsy. We should start treating with intravenous medial prednisolone, and it should be titrated based on the ESR and CRP. And majority of the patients require lifelong steroid treatment. So they should be started on, some patients may need steroid sparing agents such as methotrexate, and tocilizumab is a monoclonal antibody approved for the treatment of GCA. Coming to the posterior ischemic optic neuropathy, in this case, the patient usually don't present with the disc edema. They usually present in 3 settings. One is the patient who have undergone prolonged surgeries such as spinal surgeries or radical neck dissections. It can occur as a very uncommon complication of GCA, and it can be associated with other vascular risk factors too. So they usually present with no disc edema. Usually the perioperative PAON, they usually present with painless bilateral marker blurring of vision with no evidence of any disc edema. So the only positive findings will be the blurring of the vision and afferent pupillary defect. So in such patients, we should consider PAON as a diagnosis of exclusion, and we should work up for other causes of bilateral blurring of vision, such as cerebral loss, cerebral causes of the blurring of vision. And to conclude, NAON, the main treatment is targeted on controlling the risk factors. Look for hypertension, sleep apnea, avoid nighttime antihypertensives. And in arthritic AON, it should be considered as a medical emergency. Once after diagnosis, should be started immediately on steroids and not to wait for the biopsy. And in PAON, it's a diagnosis of exclusion and should be suspected in all cases of prolonged surgeries and whenever we suspect a patient is having a GCA. Thank you.
Thank you, Dr. Kiran, for that crisp talk. So next we have Dr. Sujitra. She'll be giving the talk on clinical insights into disc pallor. Dr. Sujitra is a professor at Amrita Institute of Medical Sciences.
Thank you, Dr. Rehana. Good afternoon, all. So, optic atrophy is a change in color of the optic disc along with defective optic nerve function. So, it results from reversible damage to retinal ganglion cell axons from the retina to lateral geniculate body. The color change is due to changes in the blood supply and axonal loss and glial tissue proliferation. So, here you can see on the right hand side is the normal optic disc, which appears bright pink in color, and in the left side, this side, you see that pale disc and with less vascularity on the optic disc surface. So here the 12-year-old girl presented with slowly progressive decrease in vision. On examination, we can see that there is mild proptosis on the right side, and vision in the right eye was 3/60. And there was RAPD, and fundus examination showed there is elevated disc, but pallor is also there, and imaging showed there is a mass just behind in the optic nerve. So it is a case of optic nerve glioma. So here the 30-year-old male presented with a decrease in vision, and there was mild proptosis, and there was decrease in vision in right eye, there was RAPD, and there is disc edema, and there was optic disc pallor, and left eye was normal, and field showed inferior altitudinal field defect, and imaging CT and MRI showed there was enlargement of optic nerve sheath and track appearance in the CT scan, which is suggestive of optic nerve sheath meningioma. Here, the 46-year-old male referred due to decreased vision in both eyes, and there was associated headache, and visual acuity was 6/18 on both eyes. Fundus examination showed pale disc on both sides, and field showed bitemporal hemianopia, and imaging showed there is pituitary macroadenoma compressing on the chiasm. In the OCT also we can see there is thinning on RNFL on the temporal quadrant, and in the GCC also you can see thinning on the binasal side, which is again classical of optic chiasmal lesion. So here it is a case of primary optic atrophy due to pituitary adenoma causing compression over chiasm. Here there is pallor on both sides. In one side you see there is bow tie atrophy, that is pallor on temporal and nasal quadrant, and superior and inferior quadrant is normal. In other side there is temporal pallor, and field showed homonymous hemianopia. So here we can locate the lesion in the optic tract. Okay. So in optic tract lesion, you have homonymous hemianopia on the contralateral side, RAPD and bow tie atrophy of the opposite side, and temporal pallor on the ipsilateral side. And when there is sectoral pallor and altitudinal field effect, we should think of AAOI, that is discussed in detail by our Dr. Kiran. So here this patient was referred from cardiology. He had loss of vision in one eye, and he presented with decrease in vision in left eye for the past 5 days. So fundus examination showed pallor in right eye, and left eye there is pallid disc edema. Here the blood investigation which showed elevated ESR and CRP, so which suggests there is vasculitis component here. So he required intravenous steroids in addition to his anticoagulant and antihypertensive medication. So here this patient, he is a known case of leukemia on chemotherapy, and he had severe anemia. He presented with decrease in vision, and fundus examination showed optic disc pallor on both sides. Here, and field defect also, superior altitudinal field defect in right eye and inferior altitudinal field defect in left eye. So it is a case of posterior ischemic optic neuropathy. Here the management is the treating the risk factors. Here the 65-year-old female who is a known case of pituitary macroadenoma underwent surgery and radiotherapy, and she presented with gradual loss of vision in both eyes after 6 months. So a fundus examination showed pale optic disc, and repeat imaging showed there is lesion, but there is no optic nerve or chiasmal compression. So this could be a case of radiation-induced optic neuropathy. Here again, there is no treatment, but new radiation protocols which reduces the incidence of injury to surrounding normal structure can reduce this radiation-induced optic neuropathy. Here again, 37-year-old female presented with decreased vision in both eyes. Fundus examination showed disc pallor in both sides, and field showed central scotoma in both sides. And in OCT also there is thinning on both sides. So here we have to think of nutritional optic neuropathy or post-neuritic or toxic optic neuropathy. He was on detailed history taking. We found out she was a strict vegetarian, and her vitamin B12 level were very low. So that lead to this optic disc damage. So it is a case of nutritional optic neuropathy, and we have to supplement vitamin B12 for this case. So coming to ophthalmoscopic classification of optic atrophy, we can classify it into primary, secondary, consecutive, and glaucomatous. In primary optic atrophy, there is no previous swelling of optic disc. The optic disc is chalky white, and margins are sharp and well-defined margins, and there will be shallow cap And retinal vessels are usually normal. Sometimes you can have attenuation of vessels also. So causes are due to retrobulbar lesions. It can be either tumor or traumatic optic neuropathy. Secondary optic neuropathy is due to long-standing swelling of optic disc. There is prior papilledema in the optic disc. The damage is due to swelling of the optic disc with glial tissue proliferation and filling the lamina cribrosa. So disc appears yellow, waxy, or dirty white in color, in contrast to primary optic atrophy, where you have chalky white optic disc with well-defined disc margins. Here the disc margins are blurred and optic cup is obliterated, and there is perivascular sheathing and retinal vessels also attenuated. Consecutive optic atrophy is due to ascending optic atrophy. It is due to retinal disease with retinal ganglion cell loss. The most common cause is retinitis pigmentosa and CRAOS. In young individual, in children, we have to think of hereditary optic neuropathy, and we have to give importance to the perinatal insults like hypoxia, and we have to do neuroimaging and skeletal survey to come to a diagnosis. And when you examine optic disc in bright light, the optic disc can appear little pale, and in high myope and in pseudophakia also, you can see that the disc may appear pale, though it is normal. And other causes for pallor of optic disc without optic atrophy is myelinated nerve fiber, optic disc coloboma, or optic disc hypoplasia. So causes of optic atrophy can be inflammation, ischemia, compression, or raised ICT, or nutritional deficiency, or toxic optic neuropathy, or hereditary conditions in childhood optic atrophy. It can be either bilateral or unilateral. So detailed clinical examination and history taking, we can come to a conclusion and we can manage. So once optic atrophy sets in, there is no specific management. We have to treat the underlying cause, and patients with low vision may benefit from low vision aids. Thank you.
Thank you, Susra ma'am, for that very nice talk with multiple cases. So we would, if there are any cases from the floor, any questions from the floor, we'll take that first. Yes, ma'am.
No questions, just a few comments. Optic neuritis, when the ONTT trial was done, which is, by the way, one of the best trials neurology has ever seen, because all treatment in neurology with steroids seem to be based on it. The saying at that time was, even if you don't treat your patient, 6 months later, they're going to get the same amount of vision. So either you treat with intravenous steroids or you don't treat. Don't give them only oral steroids, because that will increase the relapse rate. That is completely changed now. Don't ever say that to your patient, because what we know now is time is neuron. So we are racing against. The moment you make the diagnosis of optic neuritis, that it's a race to save neurons. So your blood test may go on one side, but please do the MRI stat if possible. You have to impress that on the patient, get the MRI done as quickly as possible, get the blood test sent as quickly as possible, so that we can get those steroids into you as quickly as possible. So time is neuron. That is one thing about different. We are thinking differently from the ONTT days. That's about the optic neuritis. About IIH, more and more ophthalmologists are treating INH. Neurologists are referring these patients back to ophthalmologists to treat these patients. So we have to be highly aware of what we need to do. Start Dimox 2 weeks later, the dose of Diamox at the beginning itself should be at least 500 milligrams per day. 2 weeks later, see your patient. If the fields don't show any improvement at all, improvement, you have to go by the absolute values. Don't look at only the grayscale. Look at the absolute values. There should be some improvement. Within 2 weeks, if you don't find any improvements, escalate the dose of Diamox. See them again 2 weeks later. And again, if you don't find any improvement, Diamox can be given up to a maximum of 4 grams per day, depending upon whether the patient is tolerating this dose. 3 to 4 weeks is maximum you wait for an improvement. By that time, most patients will show improvement, but there are a few that don't show improvement at all. You have to add drugs. Any other, drugs like Lasix or topiramate may be added. Usually, topiramate is what is added. One thing to be very, very cautious about this, both Diamox and topiramate are sulfur-derived drugs. So be on the watch. Even patients who have not given history of sulfur may show, when the second drug is added, may show some signs of allergy. Another funny scenario is that patients who have reported with sulfur allergy with Diamox have been treated with topiramate because that is the next best treatment for IH, but with the idea in mind that these are both sulfur drugs. Another thing about the treatment is that after the optic disc edema completely subsides, we need to continue treatment with Diamox for a period. Some people continue for 4 weeks after complete subsidence of the edema, disc edema. Some people even continue it for 8 weeks or so. And please remember, follow-up for these diseases is for life.
Ma'am, I would like to know how you follow up these patients. Like if the disc edema has completely settled, as ma'am said, the Diamox is continued for 4 weeks, 8 weeks. How will you advise them?
So first of all, I would like to congratulate all the presenters. I would say it was a wholesome presentation, just not excellent, it was wholesome. I don't have any point to add on. So everything was really good. Just one or a few points to add. Nowadays, anemia is getting more importance. Hemoglobin has to be checked for all cases of IAH as well as anterior ischemic optic neuropathy, non-arthritic anterior ischemic optic neuropathy. So please remember to check hemoglobin in all cases of NION as well as IAH. And one more thing about optic neuritis neuroimaging is MRI brain with contrast with orbit as well as spine. Spine is also important because, as you said, NMO is very common nowadays and the lesions will be severe and we should not be missing it. So it is better to add MRI spine also. And with respect to your question, we follow the patients regularly. Every visit, that is every month, we follow the patients. Once in 30 days, we call the patients. And then every visit, we do HFA also and check the progression of the visual fields, whether the visual fields is worsening or not. So if it is not worsening and the disc edema is improving, we continue with the Diamox. If the visual fields is worsening, then we advise lumbar puncture. Still worsening, then we go for shunts. And still worsening, we go for optic nerve sheath decompression. It all depends on the resolution of edema and the worsening of the visual fields. So please remember, visual fields examination is very, very important in all cases of papilledema. And Madam, optic atrophy, this is the first time I'm seeing somebody telling causes about pseudo-optic atrophy. Usually we say causes of pseudo-papilledema. That was very nice.
Yeah. I just have one question, Dr. Rehana. In your case, you had one female patient with NMO, right?
Yes.
Was serum NMO and MOG done?
Yes.
Because you're sure only CSF NMO, serum NMO.
Serum. Yeah, usually we do serum and CSF, both of them. It's basically done in a neurology clinic. So they do both of it.
Yeah, I think it is mandatory we get serum NMO and MOG done.
I think serum is more sensitive than CSF.
It is definitely sensitive.
Yeah.
Okay, along together, MOG also must be done.
Okay.
Okay, I am a neuro-ophthalmologist from Shankar Nethralaya. In our Indian scenario, the frequency of MOG is much, much more on compared to NMO.
Yeah.
Okay, as a mandatory rule, serum followed by CSF has to be done.
Okay.
And regarding IH management, how do we taper Dimox? It's like, of course, until the disc edema is resolved completely, the dosage of, TAD or BID is given. Once there's no disc edema, we do not stop at that point. We gradually taper and stop. So if the patient is on 500 milligram per day, then we give them 250 milligram for a month, and then for another
Once a day,
month,
yeah.
we reduce that to, that's how we stop it. And we again see them, call them back after 3 months. In those ladies who are planning to have their, continue with their family life or are going to have another pregnancy, we ask them to come to us before they plan their pregnancy.
Yeah.
And because once with weight gain, they're more bound to have a rebound IIH. So all patients, apart from medications, we strongly encourage them to lose weight. That's one thing.
Yeah.
And as ma'am said, we have to rule out pseudocerebral syndromes, all systemic associations where Dandy's criteria is met, but metabolic disorders must be ruled out. So especially young girls, everything is normal, their BMI is normal, and still they go ahead and develop IIH, anemia has to be ruled out. In men can also have IIH, please rule out nephrotic syndrome in them. And when for your students or postgraduates, please enforce that MRI brain orbit along with MRV must be done. And if MRV shows any pathology, a DSA must be done to rule out any vascular abnormalities or thrombosis.
Thank you. So I think we should wind up for the next.
Usually tell our postgraduates to remember very easily. The most common causes of papilledema will be three-letter words. It's a very simple thing, just I want to tell here. IAH, SOL and CVT. So to rule out SOL as space-occupying lesion, we have to do MRI. And to rule out CVT, cortical venous sinus thrombosis, we have to do a MR venogram. If both are normal, then we take it as IAH. So MRI with MR venogram, as Dr. Vidya told, it's very, very important in all cases of papilledema. And blood pressure examination is also very important. That was told in the presentations. So because many a times we confuse grade 4 hypertensive retinopathy with papilledema. So before advising neuroimaging, blood pressure examination is very, very important, and also slit lamp examination to rule out VKH. You have to look for cells and KPs because VKH also will have bilateral disc edema. So you can confuse VKH also with papilledema. So please do blood pressure and slit lamp examination before advising neuroimaging.
Thank you, ma'am. So we'll wind up our session for the next talk. Thank you all. Thank you all for coming. Thank you, ma'am, and thank you for all the speakers.